Hello, my name is Stephanie Ragdale. I'm the Admiral nurse at Macclesfield District General Hospital within East Cheshire NHS Trust. I'm presenting this topic today for Dementia UK Summer School 2021. We're going to be looking at possible causes of distress and changes in behaviour within the hospital setting. So being in hospital can sometimes be a confusing and frightening experience for a person with dementia. They may not fully understand where they are or even why they are there. Hospitals can be loud and unfamiliar environments. The ward is busy and noisy. This can add to the person's confusion, increase their levels of anxiety or agitation. Families often report that hospital makes dementia worse. They're quite often not receiving the same stimulation or emotional support that they would have done at home. People with dementia come into hospital after falls, infections, as well as other acute medical or surgical problems. This all makes them vulnerable to developing delirium. Go on to look a little bit more in detail later. All of this can lead to changes in a person's behaviour. So what might influence behaviour? Well, we have to bear in mind that it's not always or just the dementia that causes distress. Really important to consider all of the potential causes and consider that the person may be communicating unmet needs, be that physical, psychological, social or spiritual. Cognitively, we have to remember that changes in the brain will be affecting not only the person's memory, but also their judgment, orientation, their ability to plan and process. As we've already said, if they're in a hospital, they will likely be acutely unwell, putting them at increased risk of conditions such as delirium. This is likely to manifest in restlessness, agitation, rapid mood changes. They might be experiencing hallucinations, and all this might lead to them refusing to cooperate with care. They may have underlying sensory loss, such as hearing or sight loss, or they may be hypersensitive to touch. There will be physical needs, such as needing to go to the toilet, feeling thirsty, hungry, hot or cold. Psychologically, someone with dementia may misinterpret what is happening to them. For example, if we are delivering personal care, they may misinterpret that and feel like they're being physically attacked. They're likely to develop strong negative feelings about where they are and what is happening to them, and potentially respond accordingly. Socially, they'll have lost their usual support networks and routines. There may be an absence of visitors, familiar faces. As I've already said, hospital environment can be noisy. The impact of this will be particularly noticeable at peak times, such as ward rounds, staff handover periods, or visiting hours. There might be a lack of stimulation. Although the environment is busy, quite often the patient may sit for hours without stimulation. Identifying underlying causes is really important. It supports prompt intervention, it improves outcomes for the patient, and it identifies necessary referral onto specialist teams of potential follow-up following discharge. Pinch Me is a very useful acronym used generally to identify delirium, but is also quite useful for considering things that might be causing changes in behaviour within the dementia alone. So we can consider P, pain, I, infection, N, nutrition, nighttime pattern, C, constipation or continence, H, consider somebody's hydration status, M, think of their medication and their mobility, E, think about the environment or emotional causes. Treating the underlying causes of delirium, managing behavioural and psychological symptoms of dementia is really important, but we have to bear in mind that certain medications can often make delirium and dementia worse. We'll go on to look at delirium in Sundowning in a little more detail. So delirium is common. It affects around 20% of all patients in hospital, but it's poorly recognised. 50% of cases go undetected. And when a person is known to have dementia, delirium can often be missed and the symptoms can be attributed to worsening of the dementia. But delirium is a medical emergency. It's a serious condition associated with poor outcomes, longer stays in hospital, discharge to a different residence, potentially not going home, potentially requiring a move into care home, and potentially even death. But it can be prevented and treated if dealt with urgently. Its onset is usually very acute, a matter of hours or a couple of days, and it can fluctuate. It can encompass disturbances in people's attention, levels of consciousness, and their cognition. And we may see impaired sleep-wake cycles, emotional disturbances, and the person may be experiencing hallucinations and delusions. It's split into 3 subtypes: hypoactive delirium, where we're most likely to see apathy, sleepiness, and lethargy. A hyperactive delirium, where people can become agitated, restless, and aggressive. The most common type is a mixture of the two. Sundowning is the term used for changes in behaviour that occur in the evening around dusk time. Some people who have been diagnosed with dementia may experience a growing sense of anxiety at this time. The person with dementia might say that they need to go home, or they need to pick the children up, even if it's not the case. There are lots of reasons why sundowning occurs, but this can be exacerbated by that noisy and unfamiliar hospital environment. It's really important that we see behaviour as having meaning. These examples on this slide: repetition, walking about, becoming withdrawn, restless, aggressive, or agitated. These are ways that people with dementia might respond to something negative, frustrating, or confusing in their social and physical environment. It's really helpful to consider that all our personal expressions, the words that we speak, gestures we make, our actions, they have meaning. And to understand that meaning, we must consider the factors influencing the behaviour. Remember, go back to pinch me. Think about the physical, emotional, environmental aspects. And when someone does exhibit behaviours such as these, it's really important to reflect on whether it's a problem or a challenge for them, or is it us? And will our actions or our responses cause more anxiety? Or will changing our expectations of the situation affect the outcome more positively? So what can we do to help within the hospital environment? It's really important to ensure that people's hearing aids are turned on and that the glasses are clean, so that we limit any sensory deprivation. Familiar objects can be very important. Ask the family to bring them in. They can provide reassurance for the patient, as well as creating talking points between the staff and the patient. People's own casual clothes can make people feel more comfortable, but this can also help people settle into routines, such as the daytime and the nighttime. Providing a notebook with messages on can be really helpful. Not only will it remind staff so that they can reassure the patient as to when visitors are next expected, but it's also something that the patient can refer back to if they're able to. Emotional support can make a really big difference. It can bring comfort and reassurance. It's also really important that we talk to the relatives and engage them in the patient's care. so that we can understand what is normal for the person, what is new. We can ask them to consider underlying causes and ask about techniques for reducing distress. It might be helpful that they use at home. It's worth considering using behaviour monitoring charts so that we can identify patterns and triggers in somebody's behaviour. And as a multidisciplinary team, we utilise that and all the knowledge that we have of the person to consider what might be the cause of their behaviour. Important to share ideas and begin to eliminate any factors that can be discounted. And really important that we assess and treat for delirium. The best treatment for delirium and management of non-cognitive symptoms of dementia is to treat the cause, the underlying cause, or meet that unmet need. Remember, sedative medication should only be used as a last resort and given at the lowest possible dose, the shortest time possible. Using antipsychotic drugs with caution or not at all, particularly for people with conditions such as dementia with Lewy bodies. Thank you very much for listening. I shall now hand over to my colleague, Sarah Merrill.